Hello. Hi, everyone. I'm Dr. VanderWel. Just give it a minute for everything to get set up here. All right. So, I'm Dr. VanderWel. Thank you, and welcome to the Eviva live seminar. And thank you for joining us. We're going to talk about weight loss treatment options. Starting off with who are we? Eviva, our practice, been leaders and innovators in bariatric surgery for over 15 years. First in the Pacific Northwest to do a laparoscopic sleeve, first in the world to do one outpatient. Did both outpatient laparoscopic sleeves and outpatient gastric bypasses over 15 years ago now. Been a part of a bunch of different things that are part of bariatric surgery. We're the first practice in the Pacific Northwest to do an endoscopic sleeve gastroplasty, or the ESG, as well. And yeah, we're excited. I think there's it's an exciting time for people that are struggling with their weight. I think there's a lot of good options. There's a lot of hope. Eviva. So who we are, this is our team of providers. We have 3 bariatric surgeons. We have a bariatrician, MD, a medical weight loss, ARMP, 2 RDs, and 2 surgery PAs. Great team. Love these people. You'll love them too. They just really care about what they do. They really like taking care of people and being nice to people and helping them, and they're good at it. So I'm just very thankful. I'm very blessed to work with such a great team. Not just the providers, but the rest of the staff too. Get compliments every single day about how great it is to work with the people that we are that work here. So let's take a big picture view of why is obesity so hard. Why is 42% of the United States obese? I like to take a 30,000-foot view, and that is our bodies are not made to live in the 21st century. If you imagine where you are right now and you lived there 150 years ago, life was really hard. You were chopping your own wood, you were carrying water, you didn't have climate controlled houses that you lived in. All your working conditions were very challenging. Transportation was very uncomfortable and very taxing. And the foods that we ate were totally different. The way we made our food, the way we stored our food, completely different. And so now, in the 21st century, when we live in climate-controlled everything, drive cars that practically drive themselves, have sedentary jobs for most of us, and have refrigerators and cupboards filled with, and Costco to go restock them, we are in completely uncharted territory from a biologic standpoint. And everything about the comforts of modern living are wonderful, but it also makes it much, much more challenging to manage our weight. I break obesity into 6 things. 5 on this hand, 1 on this hand. Mindset, diet, exercise, psychology, support, biology. If you struggle with this one, it doesn't matter how much of your act together you seem to have on this one, you're just fighting this uphill battle against your body. Surgery is a tool to help us with this. It is just a tool. It's not a cure. It's not a magic wand, but it's a really good tool. And it changes that uphill battle into a downhill battle. So you're working with your body as opposed to against your body. So you want to lose weight. The general trope is eat less and exercise more, right? Saw that to the extreme in the Biggest Loser show. Done surgery on Biggest Loser contestants. They almost all gain their weight back, and they almost all go on to get surgery. Unfortunately, that only works for less than 5% of the population. If you are legitimately struggling with your weight, BMI above 35, your chance of losing weight to a normal weight and keeping it off is less than 5% on your own. And the reason for that is that your body just desperately wants to survive the winter, and it thinks that anytime you're in a caloric deficit, you're going to die. And so what we need are tools to help us with that, to help us with the biology piece. So what are our options? Just talked about them, the weight loss, the eat less, exercise more. This is still an important part of the story. Like, if you're not having a certain level of activity, if you are not eating a healthy food or having a right diet, like, none of the other options really matter. But this alone in itself is generally not enough, particularly the exercise one. So this is an important thing to notice, that scientifically it has been proven that exercise is not the key to weight loss. Exercise is very helpful for maintaining weight loss and for getting a jump start on weight loss. It's a great supporting actor. It is not going to win the Oscar for Best Actress. So that is one that it's important that these things go together. They're a part of the story. They're very important, but it's not the only players here. So let's talk about weight loss medications. So these are medications. I'm going to break these into maybe say legacy medications or like oral medications where you can take in a tablet form. And then there's the injectable medications like the GLP-1s that have been, kind of blown up on the scene in the last couple of years. So usually the tablet form medications, weight loss is okay, something 5 to 10%. Durability is generally dependent on if you're still taking the medication. They can have some side effects, but generally they none of them seem to be super severe unless it depends on the medication. But stopping the medications usually prevents these medications from long-term damage. But the downside is just weight loss is just very modest and it's slow. And it's kind of dependent on staying on these medications. These things still have their place, though. They still can be great tools to help people just maintain their weight loss or take the edge off or live a little bit better or bring down some of the food noise. So, like I said before, all these things are just tools. It's about making sure we're using whatever tool or combination of tools is going to be right for you. Now we're going to go into the GLP-1s. So this is GLP-1 receptor agonist. So this is like semaglutide, brand name Ozempic or Wegovy. There's tirzepatide. So here's Ozempic. Tirzepatide is mounjaro or now Zepbound, which is the FDA clearance for the same drug, just under obesity. So these drugs are injectable medications, usually once weekly. And the weight loss for these have been much better than any medication we've seen in a very long time, or if ever. Even fen-phen wasn't seeing some of the weight loss that we're seeing a little bit better now. The durability, this is a hard one. We're getting more and more data. We don't have a lot of long-term data out yet, but usually what it looks like is about like if you wanted to stay on this, if you want to be on this medication, only about 60 to 70% of the people are still on the medication at a year. And of the people that came off the medication, a significant amount of those people regained their weight back. So or gained back quite a bit of weight that they've lost. The side effects of taking the medication themselves, usually mild, like a GI, things like nausea, a feeling of early fullness, particularly, but that's just kind of the medication working. Sometimes diarrhea can be with it, but usually those are dose dependent and not super common for many patients. But yeah, they can be. Sometimes it make people stop taking medication, but a lot of times we're able to find ways of working with them still. The downside of these medications is that they can be very expensive. They can be very hard to find if you're trying to find name brand GLP-1. The pharmacies just can sell out of them. They're very expensive to do. They're $1,000 usually a month for name brand stuff. We do some compounding pharmacy. We've seen so far that's been successful. We don't get in the middleman there. We just we give you a script to a place and you exchange money with them for that. But usually it's about $200 once the dose is maximally up there for a monthly supply from a good supplier. The other thing is that we don't have a lot of like long-term data on these medications in the doses that we're using them. We have been using GLP-1s in diabetes for 5+ years, but those were pretty different. Those drugs were a little bit different, and they were also different delivery, different dosages, significantly less than what we're giving now. So it'll be interesting. We need to keep a close eye on what the long-term data shows and making sure that everything is safe and that it's effective and that we're not doing the risk benefit is favorable. But no, this has been a great thing to happen for obesity and for patients that are struggling, because there's a lot of people out there that are like, this is as far as they'll go. As far as like, I am not going to go into the procedure land. But and there's people that have had a procedure that are like, hey, I'm kind of struggling with my weight again. These medications have helped a lot of them too. So all these things are just tools. So now we're going to switch over to the procedures. And the first one here is technically a non-surgical procedure. It's endoscopic, which means that it's done through a small tube with a camera on it that actually goes down through your mouth and into your stomach. This is called the endoscopic sleeve gastroplasty, or the ESG. It is done with this cool device called the Apollo Overstitch. You can see it right here. And this thing helps us, it's essentially a suturing device that helps us suture on the inside, kind of like a sewing machine almost. And what you do is you take your stomach, which is this large bag, and you take bites that are full thickness, and you put that suture through it, and you actually crumple that stomach down into a small shape. Really cool tool, really cool potential there. And what you do is you kind of do these lots and lots of sutures. So I usually put in about somewhere between 8 and 11 sutures in most of my ESGs. And you crumple that stomach down from this large bag down to a small tube. Generally, it's very close to the size of the sleeve gastrectomy on the inside when you're done, like the shape of the space. So in our practice, we're seeing about 20 to 25% total body weight loss on average. Durability seems to be good. There's 3-year data. There's 5-year data that's out there now. There are people have published long studies where people have maintained their weight loss, which has been great. In our practice, we're seeing really cool stuff as well from a durability standpoint. Complications are rare. This is a really nice thing about the ESG is that it just you can have problems with an ESG, just like with anything. Like you can have problems getting out of bed, but it's so rare to have an issue with an ESG short term and especially long term. From like it gives you problems like with digestion or with pain or you're swallowing or things like that. Like it just almost never has issues. Very, very rarely. That's true of most of the rest of the surgeries too, but like particularly in ESG, like when someone comes to you years after an ESG, like, oh, I just started having this weird stomach issue. It's almost never the ESG. Whereas if you have like a gastric bypass on the other hand, you're like, oh boy, I need to take a look, take this, we need to really look at this and investigate this because we know that there are known issues with that long term that we need to investigate, make sure it's not that. The laparoscopic sleeve, even much less so than the gastric bypass, but nothing like the ESG. So the downside of this procedure is that it's still self-pay for almost the entire segment. We're starting to just crest into the insurance payment field. We're starting to make a little bit of progress there, but it's still very limited. We don't have as much long-term data. We don't have 10-year studies, like we do with the bariatric surgeries. We don't have 20-year studies like we do with some of the surgeries. And it's, a 4 to 7 day recovery, which is, more than taking a medication, but still usually we if you do the surgery procedure on a Wednesday or Thursday, you're back to work with on Monday. So, and usually you're back to like feeling good exercising by 7 to 10 days where you're like, getting back into light exercise. So it's been a great, that one's been a great procedure. It's been really exciting to see how that's helped people. All right, so now we're going to go into the gold standard of weight loss treatment. That's weight loss surgery. So laparoscopic bariatric surgery is hands down, no questions asked, the best tool that there is for obesity from a results standpoint, like how much weight loss you can lose and how durable it is. Like a gastric bypass or a laparoscopic sleeve there's just no question about it that is the best tool that there is, that we have right now. Weight loss is generally in the realm of 25 to 30%, 35% depending on where people stand average wise. Durability is very good. This is the best and most durable treatment. Complications are still very rare. Our complication rate in our practice is less than 0.7%. And the downsides though is that it's not always covered by insurance. And it does have like a little bit longer recovery than an ESG, but usually still very manageable. So like a lot of my desk job people, they're back to work within a week or two. But generally, like even my nurses that I do surgery on, they're back to work within 2 weeks. People that are kind of crawling around building airplanes in an airplane, they usually want to take off 3 weeks on that one. If taking off more time is helpful for people, I do really support that because I tell people the goal of these surgeries is to change your lives. It is not to get you back to work as soon as possible, but most of the time people are just kind of bored and they're ready to get back into their routine. So the surgeries themselves are done laparoscopically. So this means through tiny small incisions using a camera and small instruments. We go inside, we actually can use a little bit of CO2 gas, blow up the internal abdomen cavity. So it makes it almost like you're pregnant. And then it gives us lots of space. We can do the entire surgery through those tiny incisions. You can see that here. You see these tiny little incisions and then the camera that you look on a screen to do the whole surgery. This is the gastric bypass. So this is your stomach, and you are taking a small pouch out of your stomach and you connect it to your small intestine and reconnect it down here so that you can see this red arrow. When you eat, it goes into this small pouch. It makes you feel full, and then it slowly empties into the small intestine, but it's not really digested very much because you don't have the most of the stomach juices like the acid and the proteases that break it down, along with the bile that comes from the gallbladder and the pancreas, which sits back here. All those things are really important for breaking down your food. And those don't meet up with all the food together until in the mid-small bowel. And when you do that, it does hormonally, it does some great things that are very beneficial from a weight loss standpoint for patients. It's also very beneficial for diabetes, particularly people that are been on insulin. Like this can really help them get a really good handle on their diabetes. This is also a good operation for people that have really bad heartburn. So the laparoscopic sleeve. So this is usually the operation. This is the operation that we're doing the most in the country and the most in the world, and for good reason. It is generally very well tolerated. It's much more approachable from a conceptual standpoint than the gastric bypass is. I guess I should go the other way, huh? And what happens with the sleeve, it's a more simple machine. And just like any more simple machine, there's less things that go wrong with it initially. There's less things that go wrong with it long term. So with this one, you have your stomach, which is that big bag again, and you reduce it down to a small tube, and you remove the extra stomach. It's coming out. You're left with, your stomach goes from probably being able to fit about 3 to 4 oranges, eat pretty comfortably in there, to being about the size of a banana. So it's significantly down in size. And this organ here is a very hormonally active organ, the stomach. And it drives a lot of the feelings of your body's, feelings of hunger, feelings of satiety, blood sugar management, hypertension management, even in strange ways. And after any of these surgeries, it's just really cool to see how your body responds in very, very, very durable ways for improving your health and your weight. Long-term wise, we do worry about the risk of heartburn in this operation. That's about somewhere between 15, 25, sometimes 30% for some practices. Risk of increasing heartburn after these procedures. Many patients that still have heartburn, their heartburn actually will get better. But it's a part of the this is part of the discussions that we have around these procedures. Along with the gastric bypass, this one has issues of you can get an ulcer here. And sometimes you can get some bowel blockages in here long term. And those are things that we worry about. And we talk to you about what are the pros and cons of any of these tools. So, how do I take the next step? So reach out to us at EvivaMD.com and connect with the team, and they can kind of answer a lot of your questions, get you started, get the paperwork rolling. You get on a visit with one of us surgeons or maybe one of the PAs or the medical weight loss providers. And we have all availability to do all of our visits telehealth, which is really nice. Like today, I saw patients from all over the state and Oregon. And we have taken care of people all over literally the world, Africa to Japan, and everywhere in between. And so what's really cool is that, the time change kind of sucks on some of those ones, but it makes it very accessible to take care of people and to really help them. And when you're struggling, you're like, hey, I'm really struggling with this or with that. You don't have to take a whole day off of work to come and see us or get childcare, things like that. You just take 15, 30 minutes off, sit down with one of your providers. We can make a plan, figure out what's going on, make a plan, and do another follow-up, again, easy. So we make a plan so we review your medical history when we learn about you, what your goals are. We make a plan that's customized for you. What's going to help us make progress on becoming better. Start the journey. These are really cool tools, and they're great things. I saw some people that are a year out this morning. It's just like the best part of your day, just seeing people doing really well. So all right, so let's go over to the live Q&A session. All right. Go. All right. I think I have some questions that have been submitted here. Hold on. Chris, would you be able to resend me those questions that got submitted? Let's see here. Earlier, as I'm, and then I'll get to the couple of that have just come in. All right, got it. Here we go. All right, let's give a restart to the Q&A session. So, all right, thank you for joining us on the Q&A session. This is Dr. VanderWel, and thanks for hanging in there, everybody, with our session. And let's get to some of the questions that have been submitted and that are coming in now. So, all right, I'm worried that I've gained weight after one of my bariatric surgeries. I did kind of beat it up a little bit. Is there anything I can do to help get it back? Can the surgery be redone? Great question. This is just like we talked about earlier in the seminar. Surgery is a tool. It's not a magic wand. It's not a cure, but it can be a really good tool. And also, like any tool, it can break down. So the key to whatever surgery you've had, endoscopic sleeve gastroplasty, laparoscopic sleeve gastrectomy, gastric bypass, BPD DS, any number of exotic things in between, all of them can experience weight regain, and that can be a piece of this. That can happen, and if we're not taking care of the tool, that's a possibility. The one thing we worry about damaging it is if we stretch it out. And so that usually comes from radial force from eating too much volume at one time. Generally, I really warn patients against trying to eat until you feel full as your stop sign for eating. I'm a big believer in that you should eat a small portion size that is measured ahead of time, and that should be your stop sign where you say, hey, I have this much, and then I'm good. We're just going to stop now, and then we'll come back to, and if I feel full before I get to that portion size, then great. But if not, I'll be like, okay, I'm fine. Am I like full, couldn't feed another bite? Hopefully not. Hopefully not. When you get the feeling of fullness, when you're like, oh man, I'm full, I got to stop, I can't go another bite. What's happening there is there's stretch receptors, like little springs, a little like cellular level springs that have sensors that send signals to your brain. When they get stretched out inside of your stomach because it's getting too much food in there or too much drink or fluid, what it's telling you is, oh, we're stretching, you got to stop. And what that means is stretching, like there's stretch happening. And if that happens on a consistent basis for years, what can happen is that over time that thing will stretch out and it'll get wider. Can you make this smaller? They call it the pouch reset. Yes, it is possible to have some reduction in the size of your intestines because your intestines are smooth muscles and they naturally want to get smaller and closer together and they tighten up. So if you don't push your stomach radially, like if you don't really stretch the volume, you have the chance of kind of getting some tightening things up a little bit. The problem is that it's going to be very difficult to do. Like from a portion size, you got to be like half a cup to 3/4 cup max, and you got to be pretty consistent with that. Generally, the rule is that if you want to try to go, your best chance of going back to where you were before is taking, going to that really small portion for about as long as you've been pushing the limits. So if it's been months, then months will help you, kind of tighten things up. If it's been years, then it may take longer. But it's a place to start. If it's stretched and you're not making progress and you can't make progress, then there is an option to redo some of these surgeries. With an ESG, you can actually resuture things. With a laparoscopic sleeve, you can both resuture it down like an endoscopic sleeve, or you could actually take off the extra dilated part. Gastric bypass, same thing. You can actually endoscopically suture it and make it tighter and smaller. You can laparoscopically take off the extra stuff as well. So it is possible. I think just kind of reaching out, and we're happy to have a conversation about what we can do. But there's hope. There's always hope, and we're always happy to just keep getting back on track and try to keep doing a little better. So, um, can you take the medication after you've had a Roux-en-Y gastric bypass? Are there side effects in doing so? What are the side effects? What happens if you go off the medication? So I'm assuming that, Darlene, you're referring to, can you take medication after you've had like the GLP-1 medications? Yes, absolutely. GLP-1s and any of these surgeries have been a good combination together and actually been very helpful, and they're good. They're complementary. The side effects are generally the same side effects that other people experience, which is, usually some nausea, some potentially diarrhea, early satiation, bloating can be one. Um, rarely pancreatitis is one of the worst ones that we see that can throw people into. So these aren't necessarily any. We haven't seen them any more common or less common than in if a normal stomach. I think it's about if you do any of these medications, you want to make sure you're doing it with the help of a full team that is watching the medication, but also watching from a nutritional guidelines and really setting you up for success. Because even if, just like with anything, medication, surgery, endoscopic sleeve, if you do those things, but you're losing also a lot of muscle and as well as a lot of fat, your metabolic health is going down. You want to maintain your lean body mass and just lose the fat part. So, and that part is really important to have your diet dialed in. So, what happens if you go off the medication? So, the data shows generally that people, when they go off the medication, can gain, gain weight back. How much of that and how often is that always true? Number one, and how much of that is comes back. So far in the papers that are generally written, it is a cold turkey stop for most of these things, where you go from high levels of GLP-1 and then you're stopping. And your body generally goes into withdrawals, it gets very hungry, and you start eating and you're overshooting and you're gaining weight back. In our program, when we stop at GLP-1, we really encourage a taper, so you kind of go down slowly on it. And we have had some patients be successful with maintaining their weight loss. After that, I mean, it's short term. We're still working in, we're talking a year or less right now. But I think it is this field. I don't want to jump to too many conclusions yet about what we can and can't do with these medications. But I will say, like, in general, when someone goes off these medications, it does get a little bit harder to maintain their weight loss. So if you're having side effects, generally we're seeing those side effects go away if you stop the medication. There are rare cases of people that persist in having side effects, particularly stomach issues, like with gastroparesis things, where your stomach isn't emptying very well, and it takes a while for your stomach to kind of wake back up and empty again, as normal. So, but yeah, very good questions there on that stuff. All right. Araceli, how was the recovery? How much time does it take? The surgery, I had a tummy tuck back in 2019. They said there was no liposuction done. Okay. All right. Had a gastric bypass 20 years ago. I haven't done so well gaining. Yeah. All right. So it sounds like she's had a gastric bypass. I think it was Araceli. Had a gastric bypass a while ago, 20 years plus, and then has been experiencing some weight regain. So I would say the best thing you can do is, it's hard from a complicating standpoint to know exactly what some person's thing is. That's why every journey is very personal. And it's about figuring out what's going to be best for you and figuring out what's going to be the keys for your support and your, working on getting you the best success that you can. In general, I tell people this journey is not easy, but it's not complicated. So I generally say, like, let's focus on the things that are most important, which is healthy food, small portions, being active, managing your stress, and getting sleep. And so when someone comes back after they've gained some weight, then we're going to first start with those things and say, hey, where are we? Here's our approach. How are we doing with these things? And let's try to do a little bit better on each one of these things. I think every one of us can probably do a little bit better on all of those. Then it's going to be like, okay, let's get, and we're also going to get into the nuances of, okay, what's the lowest hanging fruit of things that you're clearly working on that, I think we're doing that we're probably not helping us and that we need to, that's going to help see some good progress there. So yeah, from a procedure standpoint, if you've had a gastric bypass, there are still several options that you can have to help. Endoscopically, we can actually tighten up that stomach pouch in there and make it smaller so that you feel a sense of fullness faster. Laparoscopically, we can do a similar thing. It has a little bit more risk to it, of course, because it's real surgery. And then we can also potentially actually lengthen the limbs of your bypass, and where you have more small intestine bypass. That is always a person case by case situation with any revision. And we talk about all the options and which ones are good for you, which ones bring what the risks are of the other ones, and if those maybe not be a good option for you, or and it's always very personalized about which one of those to do. So. All right. I'm here. Said, what should I do with bloating on my belly area? It makes me look pregnant. So, it's hard to say. Bloating wise, have you had bariatric surgery? I'm here. Was that part of it? Um, in general, I would say that when our approach to bloating is, I think we should kind of start with, the basic like workup of, hey, how are things going? Check out your labs, check out any other symptoms that you're having. Probably do some imaging, maybe an X-ray or a CT scan, maybe an endoscopy to see what's going on in there. It's going to be about timing, things like that, and then we're going to go into the diet. Say like, hey, what's going on with your diet? Do you find you're bloating more after this or more after that? Maybe if we try this sort of diet, is that going to change your symptoms and help you feel better? That's generally where we start. So bloating is a tough one though. There's so many reasons why you can have bloating, that it can be challenging to know exactly what the issue is. There's not a textbook on bloating that says the most common cause of bloating is X. But yeah, no, I think there's little things we can work on, little things we can do to look into things. Thank you for the question. And if I can be more specific, let me know. All right. How long does it take to get to surgery? So, another great question. Thank you. Um, Generally, it depends. If someone comes in and they're like, "Hey, I've had surgery. All these people I know have had surgery, and I know I'm ready for surgery. I've been doing this, 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 and this." And it's like, okay, well, let's see what workup we need to do. Do we need to do labs? Do we need an EKG? Is there any other studies we need to do? And then it's going to go to, okay, got all that stuff done. Let's get on the schedule. As far as like, are you approved for insurance? Are you going to do self pay? And then it says, okay, then usually our schedule, once we're all approved and all cleared for surgery, our schedule from a surgeon standpoint in our practice is usually about 3 to 7 weeks to get on the schedule when you're approved. So, yeah. All right. Let's see here. Thank you for that question. But otherwise, some insurances policies have like supervised diet requirements where you have to have X amount of time with X amount of visits with some sort of medical provider that they specify. And we do those visits. We follow what their policy guidelines are, and then as soon as all that's done, we put it into a packet, send it off for submission, and get approval for surgery. So. Yep, kind of the theme for a lot of these things. It's always a case by case basis of what is right for you and what is right in your policies that you have and your insurance and all those other things. So, all right. Well, been some great questions today. Really appreciate the interest and yeah. QR code just goes right to the contact us form. If you're struggling out there and you're like, hey, I'm ready to take that next step, we're here for you. This journey is really cool, and there's a lot of hope out there, and it's exciting to see. We see it every week, and it's you can be there too. So if you're struggling out there, reach out. We'd love to help. Hope you have a great day.